Everyone, welcome back. Let me remind that the presentations will take 7 minutes. The remaining time will be for Q&A and any suggestions you may have. Let me kick off this afternoon session by introducing the first speaker, the Dr. Andrea Fessler, Institute of Microbiology and Episodic, Germany.
Hello, everybody, and welcome. First of all, sorry for this problems previously. I hope it works better now. And thank you very much for having the opportunity to present this study today. Well, today it's on the topic therapy failure in veterinary medicine. And yeah, please go to the next slides. So the antimicrobial resistance is an increasing problem in human and veterinary medicine, and therefore the antimicrobial susceptibility testing is a very important tool to use the antimicrobial agents in a rational way. On the one hand, it helps to select an appropriate antimicrobial agent for the therapy, and on the other hand, it can also help to adjust the therapeutic medication in case of a therapeutic failure. Meanwhile, there are already some legal compliances which include the antimicrobial susceptibility testing for different cases. For example, in Germany, there is regulation on the veterinary pharmacies available. However, the results are not always in accordance with the clinical efficacy in vivo. And in the next couple of minutes, I want to give you some information about the possible reasons. Next slide, please. One reason for susceptibility in vitro but no efficacy in vivo can be that the diagnosis was wrong. And this can be in the clinical way, that there is just no bacterial infection, the reason for the disease. And of course, if there are no bacteria, then the antimicrobial agents are not effective. Moreover, microbiological misdiagnosis is possible. So the relevant pathogen is either not identified or detected. And for example, contaminant or some other bacteria from the normal flora, for example, in the intestinal flora, is falsely identified as a causative pathogen. And then, of course, the results of the susceptibility testing are not relevant. Moreover, the susceptibility testing method can also be not appropriate for a specific pathogen. And so not for all antimicrobial bacterial species testing methods are available. And also there might be problems with the evaluation of the results if there are no appropriate clinical breakpoints for the respective animal species with the respective combination bacterial species, indication, and antimicrobial agent available. Next slide, please. Here we have a summary regarding the differences between the antimicrobial susceptibility testing in vitro and the conditions which are present in vivo in the respective patients, and which effects these differences can have. One factor is the cell count, which is usually stable for the in vitro susceptibility testing, and is about 10 to the power of 5 of 10 to the power of 6 CFU per milliliter, but it is variable in vivo and can be even higher than these tested concentrations. Of course, this can have a possible influence on the susceptibility of clinical efficacy and decreases it in vivo. In vivo, there's also cell drivers and proteins available, and these can also reduce the efficacy in comparison to the in vitro results, since antibiotics can form protein bonds and are then less effective. The pH value is usually used in a neutral way for the susceptibility testing in vitro, but in vivo, the inflammation can lead to acidification of the tissue, and this can have a negative influence and the clinical efficacy, for example, for the aminoglycosides. The partial oxygen pressure is quite high in the normal clinical susceptibility testing, or for special cases, even also microaerophilic or anaerobe, if you have to test anaerobia bacteria. But in vivo, it's usually variable low and can be down to 0 with anaerobic conditions. And this means that this can also influence the efficacy in vivo, since some of the bacteria and the situation work better with oxygen. The presence of bivalent cations as calcium and magnesium is relatively low and in a constant way in the susceptibility testing, but it's present in physiological concentrations in vivo, and this can also decrease the efficacy, since these bivalent cations can, for example, inactivate tetracyclines. Another point is biofilm formation, which is missing or at least very low in the in vitro testing, but it can be variably be present in the in vivo. And okay, this was based on this. We have the situation that these factors need to be taken into account for the susceptibility testing. Besides the already mentioned points, also the sensitivity of bacteria can be a factor, and there are, for example, the acquisition of resistance properties, for example, resistance-mediating mutations and resistance genes, an important factor, as well as the biofilm formation and the presence of persister cells, which I will go a little bit more in detail in the next couple of slides. Next slide, please. The resistance development during medication can occur via resistance-mediating mutations, and these are commonly known for the fluoroquinolones and rifampicin. Especially for rifampicin, these mutations and even single mutations can cause an increase of the MIC values in a way that the bacteria get resistance during therapy. Therefore, single therapy with rifampicin is not recommended. There is another factor, the so-called inducible macrolide resistance, which can lead to therapy failure. In the susceptibility testing results, the erythromycin is detected as resistant, the clindamycin as susceptible, and this occurs in the presence of so-called genes. And these genes can be induced, but not all antimicrobial agents which they can confer resistance to are inducers. So that means erythromycin in this case is, but clindamycin is not. But during the medication, it can occur that the regulator region mutates, and then the gene is permanently expressed, and the bacteria resistant to all macrolides and glucosamides, which therefore shouldn't be used for the treatment in this situation. In a polymicrobial environment, the bacteria can also acquire resistance genes via mobile genetic elements, which carry these resistance genes in the present situation. And therefore, it's important that these resistance genes are located on plasmids, transposons, or integrative and conjugative elements, ICEs, or gene cassettes. Next slide, please. As mentioned before, the presence of biofilms can be also an important factor, and that means that extracellular polymer substances are produced by the microorganisms and in which they are located. And these biofilms protect the microcolonies against the external influences. For example, it works as diffusion barriers and also can include the persister cells, which I come to in the next slide. And therefore, it's of course more complicated to treat these bacteria. And this is the case, for example, in implant infections, mastitis, or pneumonia. Next slide, please. The presence of persister cells means that there is a subpopulation of bacteria which are tolerant to antimicrobial agents. And these bacteria have a reduced or missing growth factors. Sorry, still problems. I switched off the camera now. Can you please go to the next slide? Okay, there are also other reasons for the missing efficacy in vivo, and this can be due to inappropriate therapy regimes. And for example, this can be that there was not a good appropriate antimicrobial agent or formulation used. For pharmacodynamic reasons, it means that, for example, in immune suppression, there should be always bactericidal antimicrobial agents be used, because the bacteriostatic antimicrobial agents only inhibit the growth of the bacteria, whereas the immune system is required to kill the bacteria in case of bacteriostatic therapy. In case of immune suppression, after end of the therapy, the bacteria will start to grow and replicate again, and so that's not a good choice. For the pharmacokinetic reasons, the MICs cannot be reached in the infection site, might be an option. This might be due to penetration barriers, and so for example, for bone infection, it is important to use substances who can also penetrate into the bone, and these are, for example, clindamycin and doxycycline. And also penetration barriers might be the blood-brain barrier and the blood-udder barrier. Another problem might be the underdosing or too long dosing intervals. This can happen, for example, in the oral medication of animal populations. So when the antimicrobial agent is given by food or water consumption, and if the food or water consumption is reduced, either because the animals are feeling sick or the taste of the food or water is modified, this might lead to underdosing. Another thing might be that the compliance of the animal owner is not so good, that the treatment is not followed according to the instructions. And another point might be that there is unclear or wrong dosing information available, and this might be especially a problem in case of off-label use of these substances. Next slide, please. So another thing is that regarding the treatment and the dosing, that the treatment period is chosen too short. And as per label instruction, usually 2 to 3 days of therapy should still follow after the clinical symptoms are disappeared, and so the regular dosing is usually 3 to 7 days. Another problem might be that the treatment starts too late, and this is especially important if there are bacteria involved that form, for example, fibrosis or abscesses, and because these leads to reduced penetration and of the antimicrobial agents to the bacteria, and of course this results in a reduced success rate. Then the route of administration must be appropriate, and this means that also the patient's conditions need to be taken into account. For example, when patients are vomiting, the oral dosing is probably not the best idea, because then you of course don't get the required drug concentrations. And if the circulation is bad with blood pressure, then of course subcutaneous application of the substances is not the best choice to get enough antimicrobial agent to the infection site. So these factors are also of importance. Next slide, please. So the next problem that can occur is that the combination of antimicrobials is used that are not useful. Exceptions for the combinations that are useful are the potentionated sulfonamides, as well as beta-lactam and aminoglycoside combinations. What is not recommended is immunosuppressive drugs, for example, glucocorticoids, which are used with bacteriostatic antimicrobial agents, because again, the immune system is slowed down by the immunosuppression, and the bacteria are only inhibited in the growth, and as soon as the antimicrobial treatment is finished, they can grow again if they are not killed by the immune system. Then, of course, there could be interactions with other antimicrobial medication, and so the oral bioavailability can be reduced, for example, with medication against diarrhea. And what also has to be taken into account that the antimicrobial treatment cannot cure everything by itself. So it's important to also add the additional treatment which is required. That means, for example, the surgical treatment of abscesses and the removing of necrotic tissue, and not say, okay, I just give an antibiotic and do not care about anything else. And there might be also that in the cases of respiratory disease that expirants or some other substances might be used as additional treatment. Then there might be also other application errors which are associated with the handling of the antimicrobial agent. And what you never should do is mixing different drugs in the same syringe. Then it's important that the storage of the antimicrobial agents is correct and not at elevated temperatures. And of course, antimicrobial agents, as all other drugs, should not be used when they have an expired shelf life. Regarding the medication via the drinking water, it is important to take into account whether they have enough solubility, and whether there are no instabilities in aqueous solutions available. Next slide, please. Now we heard a lot about the situation that the in vitro susceptibility was there, but no in vivo efficacy. But of course, it's also possible that we have the situation the other way around, that we have no in vitro susceptibility, but in vivo efficacy. And this can also be based on a wrong microbiological diagnosis, so that we have a contaminant or another bacteria from the physiological flora as putative pathogen, but in fact the real pathogen is susceptible to our treatment. Then the effective immune system could be responsible, and then of course we have an efficacy or a treatment or no treatment failure occurring. even so that this is, of course, independent from the antimicrobial therapy. What also could happen, but I'm not sure how likely this is, that the expression of the resistance factors might be very low under in vivo conditions. And what also could happen is that there is an enrichment of certain antimicrobial agents in special tissues. And this is known, for example, for the one or the other macrolide, for example, gamithromycin. Next slide, please. Now we come to the conclusions. And as you just heard, there are multiple reasons which can lead to antimicrobial treatment failure, in addition to antimicrobial resistance. And the antimicrobial susceptibility testing, of course, increases the chance for therapeutical success, but it is not a guarantee for an in vivo efficacy. Therapy failure can occur even if the pathogen is tested as susceptible in vitro and the antimicrobial is correctly administered. And a rational antimicrobial treatment, of course, requires the understanding of the complex factors influencing the therapeutical success. Next slide, please. And now I'm at the end of my talk. And thank you very much for your attention, and sorry for the technical problems occurring during the talk.